unless everybody's protesting at that time. I'm John Tierney, and yeah, I don't know whose head's in my way here, but the rest of the slides won't. Basically says, Mr. Dittman, remember, that brain is only temporary, so don't try and think too hard with it. I think a lot of times with DRGs and short stays and such, we should give this advice as people leave the hospital. We've loaded them up with medications that have half-lives that in the elderly will achieve steady state sometime 2 or 3 months from now after they get home. And we load them up with their Coumadins and their digoxins and their Ticlids and their Antivert and all kinds of things. They go home on 15 meds that turn into turpentine 2 or 3 months later. And these people have been in the hospital with damaged brains. They came, you know, the theme today is preventing stroke, but a lot of them are old, and unfortunately, it's not unlike our computer hard drives. The older they get, the more we use them, the more cells die, and the less reserve these brains have for tolerating the stresses and abuses of day-to-day life, let alone the ones that we in the medical community inflict. Just by way of background, to kind of tell you where I'm coming from as we talk today, I trained here, med school and psychiatry, and in fact did my neurology with some of your speakers this afternoon, trained by Dr. Hart, and Dr. Luther was here then, and the whole neurology staff. And I became very interested in this middle ground between neurology and psychiatry. The neurologists call it neurobehavior, the psychiatrists call it neuropsychiatry, and it has lots of names. Some are four-letter names. But for these patients that don't fit neatly into the psychiatrist practice or the neurologist practice, we've found the stroke, we've identified where it is, we've done what we can to prevent advance of the stroke, but now the family's left with all these behavioral problems. You're talking mostly, as I understand it today, about preventing stroke. I'd like to talk with you about the clinical situation after the stroke has occurred. You come in to see this patient. How can you help? And I understand we have professions from many disciplines here, or folks from many disciplines. So I'm going to try and keep this fairly broad, and it's flexible. I've got 10 or 12 slides is all. And so some time to digress. If there are particular areas of interest or questions that you have, please let me know. Again, after having left here, I had the good fortune of training with some premier neurologists and psychiatrists, and I was just in the right place at the right time, I think. My early mentor in psychiatry was Dr. Michael Wise, and he went on to become chairman at Ochsner in New Orleans. And it was a bit star-crossed for me because one of the premier behavioral neurologists who worked with Geschwind and some of the aphasiologists, Richard Strube, has been writing this book and revising it over the years. And for those of you, particularly physicians and nurses, interested in doing good neurobehavioral assessments of demented, delirious patients, this is an excellent reference. It's written by a neurobehaviorist and a neuropsychologist, and it really takes you through a very systematic approach of how to approach cognition and language as you look to higher level cognitive things like mood, which we're going to talk about today, and trying to figure out if this aphasic patient is depressed or not, or whether they're delirious. So I had the good fortune to work under these folks for 2 years, basically rounding in the morning on patients with a psychiatrist, and then in the afternoon with a neurobehaviorist. From there, I went and joined the faculty at Emory University and ran their consult service at a university hospital comparable to what you have here for several years, and worked across inpatient settings where you've got folks with lots of the kind of problems that you'll be discussing today. And more recently I've come to direct the Geropsychiatric unit within the Baptist system across the street here at St. Luke's. So what I'd like to talk to you about this morning are the 3 Ds of what I work with typically: delirium, dementia, and depression. The 3 Ds. And I think you've got to approach them that way when you approach these patients clinically. My neurology colleagues call it encephalopathy, or they call it acute confusional states. I think they're wrong. I think it's delirium, and I think we can talk about some of the history of that briefly, but when you come to see a post-stroke patient to figure out if they're depressed, you first got to figure out if they're delirious. And you got to figure out, are there metabolic problems right now? Are there iatrogenic medical problems? Is this little old person a closet drinker? Are they going to go into alcohol withdrawal now after their stroke? Is this agitation and confusion due to other things besides just the stroke itself that they've just endured? And in figuring out that delirium, you're figuring out some of the acute problems. Delirium's not a new concept by any means. The root word is believed to come from the Latin for out of one's furrow. If anybody's seen an agitated DT's patient, it looks like they're plowing across the field in the wrong direction. They are out of their furrow. There are references in Hippocrates' writing about phrenitus and melancholia and lethargus. He knew about what I would call today, in the 90s sense of things, hyperactive delirium versus hypoactive delirium. My neurology colleagues talk about acute confusional states and delirium tremens. That's what I think of as hyperactive kinds of delirium. The Greeks knew that those were usually due to poisons or toxins of some kind, and that tends to be true today when we generalize about these things. Hypoactive delirium is the classic sort of encephalopathies, hepatic encephalopathy, that quiet, sleepy, slow, sluggish patient that you commonly call the psychiatrist to see if they're depressed. Adding an antidepressant to hepatic encephalopathy rarely helps the patient much, and a lot of times will make it worse. And so the importance, I think, of looking to this issue of delirium when you first encounter these patients. There was a beautiful paper written by some internal medicine doctors at Rochester, New York in the 1950s, and they called it Cerebral Insufficiency. And these guys were way ahead of their time. But the notion of delirium being a reversible problem of functional metabolism. In other words, that system has somehow been overwhelmed. And if you think about the brain, it gets first dibs on blood and oxygen. It can run on fumes. It can make energy lots of different ways. It has this elaborate, wonderful blood-brain barrier to protect it from toxins and from infections. And yet, we don't a lot of times get concerned enough, I think, when our little old folks get a little off. They get a little ICU psychosis. I think when you see some ICU psychosis happening, when you think delirium's happening, you got to get worried. This is brain failure. We get real worried about heart failure and lung failure and all these organs we can transplant, you know. The brain, we can't. And if the brain's been breached, if the defense systems have been breached to the brain, it usually means you've got multi-organ failure going on. You've got other systems that the brain is a harbinger that other things are going bad, and there's other things happening that we really need to look to quickly. Typically, you'll see disturbance in a level of consciousness and cognition, and we'll talk a little more about that momentarily. Almost invariably, if you had a baseline EEG on these people, you will find that their EEG has changed significantly, and it'll help you figure out delirium from depression. And typically, the characteristic EEG of delirium is for diffuse background slowing. The problem is some of these folks may have rapid background activity such that when they become delirious, they just drop to the low end of the normal range. And they drop to 8 or 9 hertz background activity when their baseline is 10 or 12 hertz. And so there's been a big relative change, and it's sort of this, sometimes the lab will help you be definitive in that, and the EEG will help, sometimes it won't. And we can talk, if you're interested, a little later about the poor man's EEG and some things you can do at the bedside. A lot of times if you've got a thrashing around patient, the neurology techs are not real happy to come up and put a whole montage on that head and try and get you an EEG. In gross terms, okay, gross terms, generalizing today, dementia, as I think of it, and I'd like you to think of it at least for this hour, is an irreversible derangement in structural metabolism, in structural function. You've lost cells. You've lost cells to things like Alzheimer's disease or strokes or Parkinson's disease. Cells are gone in an irreplaceable way. Now there's a couple exceptions. There's a couple disorders that kind of cross between delirium and dementia. But in a basic way, I think if you think about delirium as being something relatively acute, something that's functional. You got too little of some electrolyte, or too much of an anticholinergic medicine, or too much of an infection, or too little alcohol that they're used to having and they're in withdrawal now. A reversible process typically. Dementia being something where cells are lost. The hard drive is being irreversibly damaged. The problem is that folks with dementias commonly come in for elective procedures. They've been getting along okay at home. Nobody really realizes that they've got a low-grade early dementia happening. That bad brain, if you will, that brain that's already got some damage accumulating, has a much lower threshold for becoming delirious. That brain can't take the stresses of the anesthesia we're giving them, the pain meds we're giving them, and they have a much lower threshold than the 30-year-old healthy individual with millions more brain cells to tolerate those kind of things. So you commonly see both of these things together. You see delirium, and then you got to back up and get that history from the family. Did Dad stop writing the checks? Did Dad stop balancing the checkbook? Did he stop going and doing the groceries? Has he quietly been declining at home for a couple years, and has the family system been accommodating for those changes? And now Mom does the checkbook and the neighbors get the groceries, but Dad gets up in the morning and gets dressed and he eats breakfast that Mom makes, and nobody realized, yeah, he was a little forgetful, but they were missing the fact that he had this dementia brewing. Well, what about the many faces of delirium? The classic phantasia kind of hyperactive delirium, the pink elephants and the hallucinations, that's, in the physician vernacular, that's a med student diagnosis. You know, the third-year clerk can make that diagnosis. They see those and pick them out easily. The more difficult one is that hypoactive delirium. That's the tough one to tease out from depression. You know, is it delirium? Is it Parkinson's disease and some mask-like faces, or is it depression? Or, you know, the bane of our existence. They taught me in med school. You know, Dr. Hart told me, find the one lesion, find the one problem. You know, and later on he told me in the more advanced courses, well, yeah, Tierney, there's commonly more than one problem going on, and that's often the case. You get all three of these things going together, delirium, dementia, and depression, lots of overlap. And then you've got to be very selective about the interventions you make and try not to make the problems worse. This is a very busy slide. You don't need to see it all, just get the gestalt from it. The point is that premorbidly, when people come in the hospital, they can come in with a normal brain, in my simple sense of it, or they can come in with a damaged brain. And then all sorts of insults have happened to get them here. They've gotten infections, they've withdrawn from drugs, they've got uremia, they've got ammonia levels that are high from their liver failure. Maybe they've been traumatized by a stroke, or a head injury, or a concussion, or some kind of subdural. Maybe they've got some CNS pathology. Maybe they've got brain mets or cancers or other direct injury to the tissue. Maybe they're the classic, you know, sort of veteran this time of year, you know, who's been smoking for the last 40, 50 years, and they got some COPD, and they got a little renal failure, and they've got a drinking problem, and they get a little hypoxic this time of year when the molds and the cedars are up, and that's enough to push them over into a delirium that we'll talk more about. Deficiencies, B12s and folates and the classic things you're looking for, thyroid abnormalities, the vascular problems that you're going to be experts on by the end of the day. And the biggie, I think, acutely, the toxins and the drugs, and a lot of times the ones that we're prescribing. in a well-meaning way. Each specialist that comes in these days adding their state-of-the-art addition to the patient management and missing the fact that, wow, that med list is 15 items long now, and that's before we go to the PRNs. You know, the PRN list is another 6 or 7 long. Not uncommon to get some heavy metal exposures and certain environmental toxins. Some of these old homes that some of these folks are living in, lead exposures and things like that. Not real common, but a cheap and easy thing to investigate. And that's where we end up with this mix over here that I talk about in delirium, hyperactive versus hypoactive. You know, are they quiet? Are they sleepy? Do they have that slowed down thing that looks to the uninitiated, the uninformed like depression? Or are they swinging naked from an IV pole, seeing pink elephants on the wall in some hyperactive state? More commonly, the bane of the nursing existence, correct me if I'm wrong, nurses, is that they only swing naked from the IV pole and pee in the trash can in the corner in the middle of the night. And the docs come in the morning and they go, geez, what are those nurses talking about? Giving me a hard time. This guy's just laying here. He's sleepy. He's compliant. I think we got too much meds on board. And you end up with this mixed state where people wax and wane between these really agitated, confused, thrashing things and this quiet state. And they go back and forth. They have these mixed pictures of delirium. And they invariably, it's sort of Murphy's Law of medicine, they will look good when the physician rounds and damage the nursing credibility. The treatment for a lot of these things is specific sometimes when you get lucky. You reverse things, you replace things. They're grossly hyponatremic or their thyroid is really out of whack and you can replace things and reverse them. But more often than not, I think, you're doing non-specific things. You're trying to create a safe environment. You're trying to keep them from sustaining head injuries and broken hips by falling out of bed or dragging down the hall with their IVs draining behind them. Trying to do the least restrictive things with that environment to keep them in bed and keep them safe and buy you a tincture of time to figure out what's going on here. What are the emergency things that we have to reverse and that we can intervene on? And then the outcomes. Do you send a normal brain back home? Or do you take a normal brain and end up with a damaged brain? Because delirium can progress to brain injury. It can progress to death. If you get delirious, your system is very frail. Your system is frail. It's been overwhelmed either by strong medicines or a serious problem like fevers, infections. Is sort of, you know, the way 30 and 40-year-olds get delirious typically is that they've either got a injured brain, they've got a drug abuse problem, or they've been very, very low sick. They've been immune compromised, they've got bad infections, or they've got big medicines going in that are just overwhelming their system's ability to handle that and to keep an intact cognition. Or do you send a damaged brain home? And delirium tremens is a classic example of where delirium can go. Delirium goes from this agitated state of hallucination and so forth, but it can progress from that sort of agitated, kind of semi-funny war story kind of material for the med students of the swinging naked from the IV pole and having this Fantasia Walt Disney experience to seizures and coma and death if it's not treated. And fortunately these days our teams are savvy enough that it's pretty rare to see full-blown delirium tremens. More often what you see is mild alcohol withdrawal that's pretty easily managed with some benzodiazepines, and it's not altogether that common, but it's certainly something that you don't want to miss in the form of a delirium tremens when you go chasing other things. Well, let's shift gears for a few minutes and talk about the assessment of these folks. When you come in to try and figure out, okay, are they delirious or demented? There's lots of different approaches to this sort of patient. The approach I advocate is one that, with an approach like this has tons more than anybody needs. Unless they're a neurologist really working with dementia and want to do a full 1-hour workup. But if you understand the basics of this, you have a good sense of how to test the various cortical processes of the brain and to take a systematic approach to this kind of patient. The beauty of this approach by Strube and Black, as I see it, is the first thing you assess is the level of consciousness in the patient. Is there a disturbance in consciousness? Are they not sleeping? Are they sleeping too much? Are they somnolent? Are they obtunded? What's their level of consciousness right now? And what's happened in the last 12 to 24 hours? This is, a lot of times, is done from the doorway. You just look and see what's the level of consciousness here. It's not fair to test you on this material today if you're sleeping in the back row. If I don't assess your level of consciousness before I test you, I will come to wrong conclusions about your brain function. If you're sleeping in the back row right now, I could decide that you're brain injured. I could decide you have a horrible brain. This guy didn't remember anything from this lecture today. He must be aphasic. He must have a receptive aphasia. He must have a left brain that's shot. He's got no memory. This must be, oh, this is awful. This is horrible. Look at how bad this brain is. My point is that if they're not awake, it's not fair to assess any of these other things. You will draw wrong conclusions. And so what's nice about this exam, I think, is it's a pyramid that starts from the very basic. Are they awake? What is the level of consciousness? Once you've ascertained the level of consciousness, now you can test their attentiveness. Are they paying attention to their environment? Are they paying too much attention to their environment? Are they sitting in there lint picking and pulling molecules out of the air because they're over-attentive and too environmentally driven, but there's such horrible executive function that they can't synthesize it, they can't pull it together. So the wheel on the chair down here, when we're talking about cognitive function, they can't figure out what that is. And they decide you got rats in the room, you know, and they get this illusion sort of thing going, and they misinterpret stimuli in the environment. And the uninformed will tell me, hey doc, we got a new onset schizophrenia in this 70-year-old last night. They're hallucinating. They're seeing rats and all sorts of weirdness in the room. It's pretty rare to have new onset schizophrenia at 70 overnight. But if you don't kind of pull this together and see what's their ability to attend to the environment and how are they misinterpreting their environment because of faulty attentiveness. Attention is relatively simple to assess. The classic thing in the psychiatric exam and in the Folstein mini-mentals is have people do serial 7 subtractions and things like that. That's way too complicated. That's arithmetic. You got to hold stuff in your head. You got to do math. That's a higher cognitive function. That's not a memory test. That's not an attention task. Some basic sort of attention tasks are just having people repeat some numbers after you give them to them. Just some simple sequences of random numbers and see if they can get, 4 to 5 things in there. Can they do some basic attentiveness? We have some things like a paragraph of letters that we'll just read to them. It takes 30 seconds and ask them to pick out some basic, like the letter A from that little column of things. Are they paying attention to their environment? It gets a little tricky because, as you neurologists know, attention and language, boy, if their language isn't intact, you can draw wrong conclusions about their ability to attend. So very early on in a good mental status exam, you've got to look to language. You've got to look to the elements of language. Can they repeat? Can they comprehend? Can they do spontaneous speech? Can they do simple yes-no kind of questions? How much do they understand? To the aphasiologist, those 4 elements will tell them where the stroke is and what area of language is problematic. But to do a good exam at the bedside for these sort of folks, you got to kind of sort out where the language is so you can decide if they're aphasic, if they've got an expressive aphasia or a Broca's type aphasia where there's non-fluent kind of speech. I've got a really tough time as a psychiatrist figuring out more complex things like mood and thought and those sort of higher cognitive things. But you got to address that because, as you can see, this builds. If you're asleep in the back or you're not paying attention or you have some kind of language disorder, it's not fair to me to test your memory and see how your memory's working. And memory things are typically verbally driven. We ask you to remember 3 or 4 objects for 5 minutes, and then we distract you with other things. Well, if you've got certain kinds of strokes, certain kind of aphasias, your language may be awful. and you can't get those 4 words in, let alone repeat them back. But your memory might be pretty good. Your memory might be fine, but you can't communicate well. So a better test of memory includes both visual and auditory tasks. So you hide some things around the room. You take some things and hide your watch, hide your comb, hide your keys, and ask them to tell you where those are at the end of 5 minutes. And lots of people with aphasia won't be able to name it, but they can tell you where it is. And you know that their memory's intact and can proceed from there to higher cognitive functions. And my point is, as you're looking at delirium and dementia and depression, mood is a subtle thing. Mood is a higher cognitive process that's hard to relate to people. Mood is an abstract concept that a lot of people don't understand, and they don't understand how to describe it to other folks, let alone somebody who's delirious and demented. And so assessing these aspects, I think, are key. Figuring out, trying to get a handle on how much delirium and dementia may be there before you move on to the issue of depression. This is just sort of an overview of an exam like the Strube exam. There's lots of exams like this. I get no reimbursements from books sold by Dr. Strube in Black. And there's lots of good approaches to this. But what I like about this one is it takes you through language issues of verbal fluency, comprehension, memory issues, on into more complex things, and what I consider to be sort of the poor man's EEG, the ability to draw things at the bedside, correlates nicely. Clock drawings and three-dimensional kind of objects correlates nicely with how your EEG is going to look as you test higher cognitive functions. Calculations, proverbs, similarities, much higher cognitive functions that we're not going to talk much about today. But this is basically a 100-point exam that can help you quantify, when you're doing a comprehensive sort of exam, different elements of this. A lot of times, for the purpose of what we're talking about today, all you're interested in is the first 15 points. You're just interested in figuring out level of consciousness, attention, language, and memory. You're trying to tease those things out so you can draw conclusions about things like cognitive function, in particular mood. Well, let's talk about depression now, and in particular, depression following stroke. Among consultation psychiatrists, we commonly scribble this in the corner margin of our consults to remind us of the symptoms we're looking for. Does anybody still write SIG on their prescriptions? Not many new docs do, but some of us still do. Prescribe energy capsules. Is this mnemonic? Nobody knows, to my knowledge, where it came from, but it's been kicking around in psychiatry for a long time. It's just a mnemonic for the basic elements of the syndrome of depression. Is there pervasive sadness? Is there sleep disturbance in the S? Is there decreased interest in previously pleasurable activities that this patient would have enjoyed? Are there guilty ruminations, feelings of worthlessness, regret, failure, ruminating about shortcomings and flaws, and it's my fault that I had this stroke, and I'm just an awful person, and I just don't deserve all the treatment you folks are providing me. Ruminating and wallowing, if you will, in these guilty, self-deprecating kind of thoughts. What about the energy level? Typically, in classic depression, there is less energy, and people are not getting out of bed, and they're not getting up and going. Are there concentration problems? This is the pseudo-dementia of depression. People who tend to have severe depressions don't pay good attention to their environment, and they tend to forget things, and they don't have the energy and the motivation to pay attention to tasks. Commonly, if you treat a depression that's present, cognition will tend to improve if you've done a good job with your diagnostics. So figuring out concentration, tough thing, and important to look to those issues of delirium and dementia first. What's happened with appetite? What's happened with psychomotor activity? Are there changes in that? Your classic depressed person is slowed down. They're moving slower, they're talking slower. At the extreme, they may be catatonic and mute. And you'll be calling someone like me in to see, gosh, is this some really end-stage dementia? Are these people locked in? Or is this a severe depression, something that, you know, IV antidepressants or maybe even electroconvulsive therapy is going to bring this person back around? And the final asks for suicidality. Do they have a suicidal preoccupation, passive or active? And really, the S is also, I think, in here goes to the issue of sexual interest and libido, and very important, even in the elderly. I mean, a quality of life issue. Lots of patients in my practice, 70 and 80, concerned that medications have rendered them impotent and are affecting their sex life or quality of life overall. STGEC caps. So breaking it out, those are the 9 or 10 symptoms, signs to make the diagnosis of depression. For a lot of people, it's like, wow, everybody's got that. You know, well, I liken it to the question of when's an MI an MI? You know, how do you tease out indigestion and heartburn from a heart attack? Well, you go to a good doc who can tease out those things and sort out those symptoms. And they look a lot the same until you get that EKG a lot of times, or you do the exercise tolerance test, or you do the thallium study, or you do the catheterization, and you look in those vessels and see what they look like. Unfortunately, I can't just, you know, cruise up the carotid artery and look for depression. But over time, as you work with patients and you tease out the syndromes, you'll see that the problem that the cardiologist has isn't that much different from what the psychiatrist has in trying to tease out syndromes, clusters of signs and symptoms to figure out if this problem is really present and to decide on a course of action. I just want to spend a few minutes. Now, part of the problem, if that person's just had a stroke and they've got swallowing problems and they've got sleep disturbance and their appetite's off and their psychomotor activity's impaired, Dr. Tierney, is that because they're depressed or is that because of their stroke? Ouch. If I am a researcher, I'm going to use exclusive criteria for the syndrome of depression, and I'm not going to include your patient in my study of antidepressants for the population at large because there's too many confounding variables there. So I'm going to exclude your patient and say, for the purposes of my national comorbidity study, your patient doesn't have it because I can't sort that out. Exclusive criteria are commonly used in research studies. You're very exclusive. You're very picky about who you assign the diagnosis. As clinicians, we commonly use inclusive criteria across the board in medicine. We don't mind making an occasional false positive mistake. Calling somebody with something and treating them, even though it may be a false positive. Okay? And that's true whether we think they got pneumonia. Gosh, if we got some Cipro that isn't going to hurt them, there's lots of family docs out in the world, they're going to say, well, they got most of the symptoms, I'm not sure, the cultures aren't back yet, I'm going to include them and say they got it and treat them. Increasingly that's true, fortunately, in the syndrome of depression as well. If you've got somebody who's got 5 or 7 out of 9 symptoms, and you're not sure if a couple of those symptoms may be due to a comorbid process like a stroke or a cancer, and you've got a medicine like sertraline or Zoloft that carries very little in the way of risks or interactions or side effects, and you've only got them in the hospital 3 days and then they're going 1,000 miles out into West Texas, you may start a little Zoloft and include them and run the risk, take the risk of making a false positive mistake and calling somebody with depression that doesn't have it. Another approach is to use substitutive criteria. In certain big research centers where they work with a lot of cancer patients or stroke patients, will start tailoring the criteria and training their people to substitute things for the strict diagnostic criteria for depression. The etiologic approach, I won't even go into it. Let's back up. Let's pause from the slides for a minute. Let's talk about stroke. Anybody got any idea how often depression occurs with stroke? Pretty high. it's kind of controversial because it's hard to study. What do you do with the aphasic patients? Do you include them in your study and try and figure out if they're depressed or not? It's a tough thing to do. The Robinson group at Johns Hopkins has been studying this for probably the last 20 years. That's probably the largest cohort of post-stroke depressed patients. Fortunately, in our community, we have a protege of Dr. Robinson and Helen Mayberg over at the Imaging Center, and she did a lot of this original work with the Robinson group. The Robinson group is relocated now in the breadbasket of our country in Iowa, and they're still continuing and following a lot of this cohort of patients. But basically, Robinson started studying post-stroke patients back in the early to mid-'80s. He selected a cohort of 103 stroke patients and been following them for like the last 10 or 20 years. In those studies, they have found that depression occurs in 30 to 50% of post-stroke patients within the 2 years following the stroke. Over the years, lots of people, famous psychiatrists and neurologists, Kreplin in 1920, looked at vascular problems and mused that there was some correlation there. Babinski in the 1920s talked about particular emotional states occurring after lesions in certain parts of the brain. Goldstein, Bleuler, very famous psychiatrist in the 1950s, observed an association between cerebrovascular disease and mood states at autopsy. And then we got off track. In the 60s, people said, oh, you know, who wouldn't be depressed after, a little sad after a stroke? You know, it's not a syndrome, and we should probably drift away from that and leave it alone. And then in the 80s, Robinson and his group really started to try and do more systematic studies. And they found some interesting things, and really a little bit contrary to what they expected to find, I think. They were looking at, for those of you that are familiar with the aphasia research, back in the 1860s, guys like Broca were noticing these lesions in certain parts of the brain and started drawing correlations with language problems and found Broca's area and Wernicke's area and things like that, and drew the correlation with that part of the brain being damaged and certain syndromes of language. We couldn't do that today because we got these big, huge things and we got so much information. We look into the fish tank now with these big, super powerful Hubble microscopes, you know, and we see so much information that aphasiologists these days, I think they know too much. It's like they're telling me which cells are doing which in the cerebellum and here and there, and they hate it when I talk about Broca's aphasia and Wernicke's aphasia because it's not specific enough and it really doesn't describe everything we know. I think if folks like Robinson and Mayberg were working in the 1860s thinking about mood, we might have had some areas of mood like Broca's and Wernicke's that we would say, hey, these certain areas will cause certain syndromes, and it would be useful to us as clinicians. And Robinson and their group, I think, were very excited initially that they might find that for us. To a certain extent they did, but I think in some ways their tools are so powerful that we're looking beyond to layers beneath, and with time that's going to be very helpful, but right now as a clinician it's a little confusing. Let me try and sort out the confusion and tell you that in these studies of these hundreds of patients that the Robinson group has studied, left brain strokes, left frontal strokes are much more strongly correlated with post-stroke depressive illness. The bigger the stroke and the more anterior on the left side of the brain, the more likely there will be depression. And I think initially these authors were excited that, wow, they're going to find the Robinson depression area in the brain. And that right brain lesions, especially anteriorly located lesions, are more likely to be associated with, they thought initially, maybe manic states. There's a lot of excitement about that, and they still are cross-referencing and slicing this data in different ways to kind of see what future studies might be done. But for the purposes of our discussion today, what seems to be a pretty strong association is if you've got a left frontal, no matter which hemisphere is dominant for that individual, whether they're right brain or left brain dominant, right-handed or left-handed, the correlation still seems to hold. The larger the lesion, left frontal, the more likely there is to be post-stroke depression in the ensuing couple years. The more posterior on the right brain, the more likely there is to be a post-stroke depression according to these studies. There is a third condition that these folks have identified that's sort of a third mood disorder, if you will. These right brain lesions commonly present with indifferent, apathetic kind of states. And often you will have what the neurologists in this area will call prosody problems, that these patients can no longer assign correct emotional tone to their thoughts and their expressions. And a lot of times there is both expressive aprosody or prosody problems as well as receptive prosody problems. In other words, if I get right in your face right now and start yelling at you and being real ugly in the tone of my voice, the prosody that's assigned, a person with an aprosody won't get it. I'm yelling at them. I'm just being really ugly. They might read the facial expressions, but the tone they often won't pick up on. And this is the sort of thing, too, that you come in and if you've got prosody problems and right brain lesions, you may decide that person's depressed, when in fact, it's not so much, it's sort of there's this monotonous quality to their emotional expression, more of an apathetic state that at least in the studies until now, the antidepressants don't seem to be as effective in reaching, that it really doesn't seem to be a true depressive condition, at least if we use medication response as a guide to that. What's the importance of that information? I think just knowing from the MRIs and the imaging and so forth, it's helpful to kind of be considering what your threshold for intervention might be based on where the lesion is located. It's not definitive. It's not the equivalent of doing an angiogram and finding that there's 3 vessels blocked in the heart. But it does kind of help you decide, wow, they got a big left brain lesion. This person's really at risk for depression. When we get this post-stroke delirium cleared up and rule out vascular dementia over the next couple days and weeks, we might have a low threshold for treating this patient to try and help reverse the depression that they're very at risk for. Well, what about the medications? I want to talk about that for a few minutes and some of the interventions that are available. And wrap up and see if you have any questions. There's an exciting thing, too, that I want to tease you with as you're talking about anticoagulation and platelets and vessels. You know, we've talked forever about coronary artery disease, CAD, like it only occurs in the heart. You know, that coronary artery disease, I mean, it's happening everywhere. They're plaquing all their vessels, typically. Now, they may not be manifesting symptoms elsewhere, but it's sure happening in the neck and the head as well. That we got to look at the whole system, and I think that's the beauty of being a neuropsychiatrist, that we get to kind of look at all of it and have the most fun with the most important one, I think, the brain and the subtleties of behavior that are manifest. There's a real interesting study, unrelated to stroke, but coronary artery disease. Fraser Smith and some Canadians a year or so ago, I think in the Archives of Internal Medicine, or JAMA, a wonderful study looking at morbidity following heart attack, post-MI. 6 months post-MI, depressed patients, much higher morbidity. Much higher morbidity. Across this, right upstairs, when they're studying how antidepressants work, they use platelets. They study platelets. Because the receptors on the platelets, well, first of all, because it's hard to get anybody to volunteer to give you neurons to put on a petri dish. And platelets are an excellent model for the neuron. They have very similar receptor densities and responses to antidepressant drugs. Out of this Fraser-Smith study, people are postulating that there may be a common underlying etiology to abnormal platelet aggregation and to what's happening in depression. That maybe what's happening in the brain with neurons that are prone to depression is similar to what's happening to platelets in the periphery, because platelets respond very similarly to antidepressants. That's kind of gee whiz, I can't prove that. That's hypothesis. They didn't even hypothesis. I mean, it's just sort of the musing of people in their discussion sections of these articles. But I think as we talk about stroke today, what if Robinson does the same, replicates the Fraser-Smith study in the next year post-stroke? Are there platelet aggregation problems that by treating depression we may be ameliorating in some way? I don't know, but it's exciting for we neuropsychiatrists sort of legitimize our existence. When we're talking about delirium, you got to think anticholinergic medicines. What's the new medicine out for Alzheimer's disease? Anybody know? Came out a couple weeks ago? Aricept, exactly. What does it do? It's a cholinesterase inhibitor. Silver bullet, just goes to the brain and enhances the brain's use of acetylcholine. What do so many of the medicines we give little old people do? They're anti-acetylcholine. They're anticholinergic. They make people goofy and confused. Benadryl's the worst here in South Texas for making people confused. How many of you take a big slug, 100 milligrams of Benadryl before you come to work? Anybody? The one sleeping in the back? Yeah, exactly. You know? And it's like Benadryl's a great antihistamine, but it's massively anticholinergic. You want to have an out-of-body experience this weekend? Take a bottle of Benadryl to the mountains, you know, and you'd be out here somewhere. The outer orbit.
It's also cheap.
It's cheap, yeah, exactly. It's cheap, and every intern learns while it's over the counter how much damage can I do with this, you know? I'm going to use lots of it. It's my friend, you know? And those darn psychiatrists, all their meds are evil, you know? I come on board in South Texas, and I look at a med list. Man, the first thing they want rid of is that psychiatric stuff. We know it makes people crazy. It's the worst, you know? It's anticholinergic, antihistaminic, and antipsychotic. My friend, also from Johns Hopkins, Larry Toon, went to the lab. He said, doggone it, we can't be the worst. He went in and he measured the atropine equivalent of a number of commonly prescribed medications. Hasn't been replicated by a non-psychiatrist. That needs to be done, I know. But Larry's a psychiatrist and a neurologist, worked at Hopkins with Folstein. He went in, prednisone, one of the most anticholinergic medicines. Diphenhydramine, anybody know what that is? Benadryl, close second to prednisone for anticholinergic equivalent. Digoxin, use that ever for AFib? Well, you're going to use a lot of that, I bet, in your stroke prevention. Procardia, phenobarb, hydroxyzine, anybody know what that is? Recognize that? Vistaril, yeah, that's, how bad can that be? You can get it at the drugstore. Coumadin, going to use any of that in these patients? Perzantine, codeine, maybe. Ranitidine, little Lasix maybe, little Lasix for that blood pressure. There's my medicine, nortriptyline, Pamelor, way down the list. Trazodone, triazolam, amantadine, no anticholinergic at all. I commonly read lists like this. You know, when I come to see that delirious, demented, confused, rule out depression patient, and we didn't even get to the PRNs yet, you know, and everybody's saying, man, get rid of that nortriptyline, man, it's making them goofy, you know. It's like, well, you know, get rid of some of that digoxin, you know. Nortriptyline was one of the first medicines studied in post-stroke depression. Nortriptyline for melancholic depression is still one of the best. Pamelor is one of the common brand names. The nice thing about nortriptyline in psychiatry is, one, that it works so well and it's so old and there's so much good clinical information about it, and it's one of the only antidepressants with a therapeutic blood level. You get their blood level between 50 and 150 nanograms per milliliter, you're in the therapeutic range. Not too high, not too low. It's nice. It's excellent in geriatric psychiatry for severe melancholic depression. Problem is, it's a class 1A antiarrhythmic, and it can slow conduction through the His-Purkinje system, and all the interns in their ER rotations saw an overdose or two on tricyclics, and they think that stuff's poison. It kills the heart. It kills my patients. Well, an overdose it does, but so do a bunch of these, you know. Nortriptyline, you got to screen the EKG. You got to make sure they don't have bundle blocks and prolonged QT intervals. But you can follow the level, and it's an excellent antidepressant. It's one of the few that's been studied in post-stroke patients. my busy slide. I shouldn't wrap up with this, but I'm just going to show you, in all the confusion from the drug reps telling you what this medicine does and what that medicine does, there's a list of kind of the old famous Elavils and doxepins and imipramines. Here's the secondary amines, dizipramine and nortriptyline. They're nice in the elderly because they don't require much liver metabolism, okay? They don't require much conversion. They don't have active metabolites. They're less likely to accumulate. The big thing, the way we think most antidepressants work is they hit norepinephrine or serotonin and shift the equilibrium of those systems in the brain to reverse depression. To date, almost without exception, any antidepressant proven effective works on those systems. Of all the antidepressants on the market today, no antidepressant company can claim they've got a better drug that works better for depression. They can claim that they have a more favorable side effect profile. That they can claim. That was the big breakthrough with Prozac in 1988. It was much cleaner. Because over here, see those old Elavils and Sinequans? They were very anticholinergic. They had alpha-1 activity, histamine activity. So they gave them the dry mouth, the orthostatic hypotension, constipation, and confusion before you could get to a therapeutic dose. Nortriptyline has it, and we psychiatrists obsess and ruminate and feel bad that our medicine has anticholinergic properties. But Dr. Toon did that beautiful table. Nortriptyline, in his study, yet to be replicated by a non-psychiatrist, was less anticholinergic than Lasix in the lab. And how many little old folks are getting Lasix? How bad should I feel about giving them a little bit of nortriptyline? You know? Yeah, it can have some anticholinergic stuff and maybe symptomatic even. But it's not as bad as a lot of things that are essential and that they're going to require. Here's some of the newer drugs. The newer drugs, Prozac, Paxil, and Zoloft, hit the serotonin system much harder. They're called selective serotonin reuptake inhibitors as a consequence. But increasingly in the last few years, we've found these things are so selective for serotonin, some people's depressions truly seem to need both norepinephrine intervention as well as serotonin intervention. And so some of the newer agents that hit both systems are gaining quite a bit of excitement. I like Prozac for my patients, but I don't like it for my medically sick geriatric patients. Prozac has a primary metabolite that takes 3 days to reach steady state. It has a secondary metabolite that takes 7 days in a healthy young individual. You do the math, about 5 half-lives, it's 4 to 6 weeks before you're to steady state with Prozac. How much do I give them? What's too much? All those things become problematic with Prozac because of this long half-life that is lovely in your 30-year-old housewife, no other meds, no other problems. That easy half-life is an advantage. That long, slow in, slow out. But in your little old, 15, 20 med list, you want short half-lives. You want 12, 24-hour half-life. So you're at steady state in 5 days, so you can draw conclusions about drug-drug interactions if they occur. And the big excitement these days is about choosing meds that have minimal drug-drug interactions, that aren't going to slow the metabolism of those other medicines that the patient's on, boost levels or enhance metabolism. Sertraline's been around about the longest, Zoloft, and there's a little more clinical information about it. It's got a standard 24-hour half-life, comes in a 50 milligram size. We break it and give people 25 or less. Paxil, there's some debate in the literature about whether it has some anticholinergic properties. It has a strong, strong affinity for the serotonin receptors that may actually be a little too much. We use Paxil and Zoloft in our elderly patients, but the edge has kind of gone to sertraline for us just because it's been around a little longer. To my knowledge, there's been no specific study done in post-stroke patients, but I expect it'll be done sometime soon. Sertraline can slow the metabolism of other drugs, but at 25 milligrams to 50 milligrams, that's a minimal likelihood and certainly no bigger problem than the other 15 meds they're taking. There's a lot of excitement. You see the ads these days about venlafaxine, Effexor. Effexor is very nice because it has an even shorter half-life. It seems very clean as far as drug-drug interactions. And in spite of this slide, it actually is a very strong norepinephrine drug as well as a serotonin drug. So it hits both systems pretty well. Remains to be studied in the population, and the drawback is, since it works on norepinephrine, it can cause transient elevations in diastolic blood pressures. Obviously not something that's desirable in your hypertensive, overweight, post-stroke patient. And so that will bear watching and further study. Start low, go slow, don't quit is kind of the rule in the elderly. Unfortunately, most of the HMOs and providers don't want you to go slow. They want you to go fast. They want you to load up those meds, prove that you've done an intervention on that master treatment plan, and get them home. But unfortunately, that isn't always the best way. Thanks very much for letting me come this morning. There's a lot of excitement about that right now and lots of study going on. I don't. Now, in postmenopausal women, I certainly try and make sure that they've got replacement and that they're, for lots of reasons. And certainly if depression is a question there. But as far as an adjunct to antidepressant therapy in my other patients, I'm not using it at this point, though there's a lot of discussion about that. And there's a complex interplay that the neuroscientists are identifying. Dr. Reiter, our famous, melatonin doc here at, has been telling us the pineal gland's the seat of the soul forever. And, melatonin is in the pathway of production to serotonin. All these things are related, and it's really exciting that in the next 10 years or so, we're going to know lots about the interplay of all these endocrine systems and circadian rhythms and baseline mood states and all of those things. Yeah. In the back? Yes, sir.
Yes, could you briefly talk about your use of lithium as an adjunct or single medicine and in the elderly, the Ritalin?
Right. Unfortunately, let me qualify what I say by saying these are really tough populations to study. And it's really hard to find good, careful, double-blind, placebo-controlled crossover studies on these kind of problems. No drug company wants to do them in the old folks. All these studies are done in young, healthy folks, and then we end up extrapolating from the clinical literature as we try things in the elderly. I try to do as much as I can with standard antidepressant treatment initially. And the issue of stimulants, that have gone round and round about those. The folks at Harvard are convinced they have antidepressant properties, and they lecture about that. Nemiroff and others at Duke and Emory think that's hogwash, and they think they are not antidepressants. I think the middle ground is that they are stimulants. And in a really cachectic, wasted, not eating elderly person, low doses, tinctures of stimulants can really help them get the energy, get awake, get some food, and can help be a useful adjunct to treatment. And they're very benign from a cardiac standpoint, maybe bumping the pulse a little bit, especially if you use low doses. And so we commonly use those. Lithium, much trickier in the elderly. There's a lot of excitement that the lithium mechanism is probably intracellular and a second messenger system, and it really does something to help reset receptor densities important to depression and mood control. But lithium's a very tricky medicine to use in the elderly because of fluctuating renal levels or performance, how creatinine and BUN can deceive you in the elderly without a 24-hour creatinine clearance. I'm actually very excited about Bowden's work and some of the other folks here in Texas. Depakote, I think, is an easier medicine to use in the elderly and the medically ill, and I hope that that's going to bear out over time as a mood stabilizer and an adjunct, though the work on that is so new in the last couple of years that it's hard to know. Many of my colleagues do use lithium. I've used lithium as an adjunct, especially if there's any hint that there's a bipolar or manic depressive quality to it. Yeah. Other questions? Okay. Well, thank you.